What if your body holds secrets, subtle variations that influence your health and comfort, yet often go completely unnoticed? Let's start with something you literally breathe through every moment, your nose. The wall dividing your nostrils, known as your nasal septum, is almost certainly not straight. Studies indicate that around 80% of people have some degree of septal deviation, a staggering figure that isn't a typo. Most individuals live with slightly crooked internal nose walls without ever realizing it. This septum, composed of cartilage and bone, separates your two nasal passages. While an ideal, perfectly symmetrical septum allows equal airflow through both sides, in reality, most shift to one side, narrowing one passage and widening the other. Mild deviations typically cause no noticeable issues, but moderate ones can lead to chronic congestion on one side, louder breathing, and snoring. Severe deviations, however, significantly obstruct airflow and can contribute to sleep apnea. Many attribute these symptoms to allergies, sinus problems, or simply their natural breathing patterns, often taking antihistamines for years without addressing the underlying structural issue. Correction usually requires surgery, specifically a septoplasty, which straightens the cartilage through the nostrils with no external incisions. Most patients report dramatic improvements in their breathing, yet many who would benefit never seek a diagnosis because their symptoms have become normalized over time. Beyond your nose, consider your spine. If you look at someone from behind, are their shoulders level? Do their hips sit at the same height? While slight asymmetry could be poor posture, it might also indicate a structural curvature of the spine, known as scoliosis. Severe cases are often obvious and necessitate intervention, but mild scoliosis, characterized by curves of 10 to 25 degrees, frequently goes unnoticed for years, even a lifetime. Instead of running straight, the spine develops a slight S or C shape. In adults, mild scoliosis typically doesn't cause significant pain on its own, but it invariably creates compensation patterns. One shoulder might sit higher, one hip protrude further, leading to an uneven distribution of weight throughout the body. Over decades, this imbalance can contribute to chronic back pain, muscle fatigue, and hip problems, all often attributed to factors other than the underlying spinal curve. Many adults with mild scoliosis were never screened as children or had their condition dismissed as insignificant, often being advised to work on their posture when the core issue is structural. Now, let's look at your foundation, your feet. Roughly 30% of people have flat feet, meaning the arch on the inside of their foot has partially or fully collapsed. Many are unaware it affects anything beyond how their shoes wear out. Foot arches are vital shock absorbers, efficiently distributing the force of each step through the foot structure. When an arch collapses, this distribution changes, causing the ankle to roll inward, a condition called overpronation. As compensation, the knees track slightly inward, and the hips and lower back adjust to accommodate these altered mechanics. Individuals with flat feet commonly experience knee pain, shin splints, plantar fasciitis, and lower back pain. They often visit doctors for each complaint separately, treating symptoms without identifying the root cause. This connection is frequently missed because flat feet themselves are often not painful. The foot may look fine, while the pain appears elsewhere and seems unrelated. Arch supports and specific footwear can significantly reduce this downstream pain. The majority of people with flat feet spend years managing knee and back issues without ever addressing the fundamental problem at ground level. While you're examining your feet, hold one out and look at your toes. If your second toe extends past your big toe, you have Morton's toe. This genetic variation affects between 10 and 30% of the population and subtly influences every step you take. In a typical foot, the big toe bears the most weight during gait, acting as the last point of contact before the foot leaves the ground. When the second toe is longer, this weight distribution shifts, causing the big toe to lose its leverage advantage and the forefoot to bear more pressure than it should. This can lead to calluses forming under the second metatarsal head, an increased risk of bunions, and altered gait mechanics that propagate up the kinetic chain, subtly changing hip rotation and leading to lower back compensation. Morton's toe is also associated with Morton's neuroma, a painful thickening of nerve tissue between the toes, and metatarsalgia, a chronic forefoot pain. Most individuals with this toe length variation never connect it to these seemingly unrelated downstream issues. Moving up the body, let's consider your posture. Your head weighs roughly 4.5 to 5.5 kilograms. When it's perfectly aligned over your spine, this weight is distributed efficiently. However, for every 2.5 centimeters your head moves forward from this neutral position, the effective load on your neck approximately doubles. If your head is just 6 centimeters forward, your neck is suddenly managing the equivalent of 18 kilograms. This is known as forward head posture, where your skull is positioned in front of your shoulders rather than stacked directly above them. Years of looking at phones, computers, and desk work train your body into this position. What begins as a muscular habit gradually transforms into a structural change. The cervical vertebrae remodel, and the muscles at the back of the neck become chronically shortened. Symptoms include persistent neck pain, shoulder tension, headaches originating at the base of the skull, and jaw problems due to the altered relationship between the head and neck. Individuals often treat each symptom separately, resorting to physical therapy, headache medication, or jaw guards, without realizing the underlying issue is a structural positioning that developed so gradually it simply stopped feeling wrong. Now, take a moment to look at your pinky finger. Does it bend slightly inward toward your ring finger? This subtle curvature has a name: clinodactyly. It describes the bending or curving of a finger in the plane of the palm, most commonly affecting the little finger. Approximately 10% of people have some degree of clinodactyly. In the vast majority of cases, it's purely cosmetic, causing no functional limitation. The finger simply points at a slight angle. This condition is usually genetic, often running in families without anyone ever naming it. It can appear as an isolated variation, or alongside other conditions. With mild cases being so common, they're often not even considered abnormal. Individuals with clinodactyly typically only notice their finger looks different when they specifically pay attention, then proceed through their entire lives without it ever being a significant concern. While more severe cases can affect finger function and have surgical correction options, most people who possess this trait have likely never given it a second thought. Let's delve inside your mouth. Underneath your tongue, a band of tissue called the lingual frenulum connects it to the floor of your mouth. For some individuals, this band is shorter, thicker, or positioned further forward than typical restricting tongue movement. This condition is known as ankyloglossia, more commonly called tongue tie. While frequently discussed in infants due to its impact on breastfeeding, mild to moderate cases in adults often go largely undiagnosed. The tongue compensates through alternative movement patterns, leading the jaw, neck, and throat muscles to recruit differently. In adults, tongue tie can contribute to speech patterns that sound like difficulty with certain letters, accelerated tooth decay from reduced saliva distribution, tension in the jaw and neck, and even sleep-disordered breathing because tongue positioning significantly affects airway dynamics during sleep. Most adults who have it developed compensations in childhood and have never had a name for this structural issue. Diagnosis requires a practitioner specifically trained to identify it. Now, press the center of your chest. For most individuals, the sternum sits roughly level with the ribs. However, in about 1 in 300 people, there's a noticeable depression where the sternum sinks inward, creating a hollow in the center of the chest. This is pectus excavatum, sometimes referred to as funnel chest. Mild cases are often hidden under clothing and largely go unnoticed. The individual might be aware of a slight indentation, but doesn't give it much thought. In moderate to severe cases, this depression can slightly displace the heart to the left and limit lung expansion. Those affected may experience reduced exercise tolerance, shortness of breath during exertion, and heart palpitations, symptoms often attributed to fitness levels or anxiety for years. The psychological impact of mild to moderate cases is also frequently underestimated, with many individuals avoiding situations requiring them to remove their shirt well into adulthood, without ever having a name for why the center of their chest looks different. Next, let's observe your shoulders. Ask someone to push against a wall with their arms extended and look at their shoulder blades from behind. While most people's blades lie flat, for some, one blade lifts away from the rib cage, creating a distinctive wing-like protrusion. This winged scapula occurs when the muscles stabilizing the shoulder blade to the rib cage weaken, or when the nerve supplying those muscles is damaged. The long thoracic nerve, which controls the serratus anterior muscle, is particularly susceptible to compression injuries. Individuals with mild winged scapula often don't notice it until someone else points it out. They might experience limited shoulder mobility, a vague ache around the shoulder blade, or weakness during overhead movements. For years, the condition is often dismissed as simply bad posture, with physical therapists and gym trainers advising general shoulder stability exercises without identifying the specific structural issue. Targeted rehabilitation focusing on serratus anterior weakness, however, can directly address it. Now, stand barefoot and have someone observe your hips from behind. For most people, they are level. However, for a significant portion of the population, one hip sits higher, indicating that one leg is anatomically shorter than the other. Leg length discrepancies of up to 20 millimeters are extremely common. This asymmetry means that every step involves a slight hip drop on the shorter side. Over a lifetime of walking, this translates into compensatory curvature in the lumbar spine, hip misalignment, and the entire musculoskeletal chain adapting to the imbalance. Individuals with unequal leg length frequently experience chronic low back pain, hip pain, and knee problems, often on the shorter leg side. They might notice that their shoes wear differently between feet, attributing it to gait habits rather than a structural cause. A simple diagnosis involves measuring leg length during a medical examination, which is surprisingly not routinely done. A small heel lift placed in the shoe of the shorter leg can significantly reduce these compensation patterns, yet many people manage years of back pain without this straightforward intervention. Open your mouth wide and look at the small piece of tissue hanging at the back of your throat. That's your uvula. For most people, it's a single, rounded piece. However, in about 1 to 2% of the population, it's forked, split down the middle into two distinct lobes instead of one. This is known as a bifid uvula. It's considered a microform of cleft palate, indicating that the tissue forming the palate didn't fully fuse in the midline during fetal development. A bifid uvula can appear alone or alongside a submucous cleft palate, where a split in the palate muscle is hidden beneath intact mucosa. Most individuals with a bifid uvula experience no symptoms and never notice it, though some may have associated speech or swallowing characteristics. It's typically diagnosed only when someone happens to look far enough back into the throat. The simple reason most adults don't know if they have it is that nobody regularly checks their own uvula. Now look in the mirror and examine the area just in front of your ear, where it attaches to the side of your head. Some people have a tiny pinhole there, a small indent barely a millimeter across. This is a preauricular pit, a congenital remnant from ear development. During fetal development, the ear forms from 6 small tissue mounds called hillocks that fuse together. Incomplete fusion leaves a small sinus tract, a narrow tube extending beneath the skin. Approximately 1 in 100 people have it, and most are unaware because it typically causes no issues. The pit is painless and barely visible unless you're actively looking for it. Occasionally, however, these pits can become infected, particularly if debris collects in the tract. Those who experience swelling near their ear canal and are unaware of the pit often have no idea why it's happening. It's considered an evolutionary vestige, a fascinating remnant of our early development. Next, a truly unexpected anatomical variation. During fetal development, your body forms along a milk line, extending from the armpit down through the chest and abdomen toward the groin, the same path where nursing animals develop multiple nipples. In humans, all tissue along this line, except for the 2 primary nipples, typically regresses before birth. However, sometimes this regression isn't complete. Estimates vary significantly between studies, but somewhere between 1 in 18 and 1 in 100 people have an additional or supernumerary nipple somewhere along this line. These extra nipples are almost always mistaken for moles, as they are typically small and may lack an obvious areola. While most are found on the torso below the primary nipples, they can appear anywhere along the milk line. Medically, they are insignificant in almost all cases, having no function and causing no problems. Yet, many who have them are simply told by doctors that it's just a mole, because often, a closer look isn't taken. Let's return to your feet for another hidden detail. The navicular is a bone in your foot located near the arch. In a small percentage of people, a secondary piece of bone develops alongside it, known as an accessory navicular. This extra bone can sit in the soft tissue of the arch, sometimes fused to the main navicular bone, and sometimes floating separately. Approximately 4% to 14% of individuals have an accessory navicular. While most never know it exists, in others, this extra bone causes a prominent bony bump on the inner arch and chronic pain during activity. The pain pattern almost exactly mimics plantar fasciitis, arch pain that increases with activity and improves with rest. Many people with symptomatic accessory navicular spend months or years treating what they believe is plantar fasciitis without improvement, precisely because that's not their actual condition. Diagnosis requires an X-ray, specifically including the midfoot, as standard foot X-rays are often angled in a way that can miss it. A proper diagnosis, of course, completely changes the treatment approach. Finally, let's consider your core. Your abdominal muscles run in two parallel bands down the center of your torso, separated by a band of connective tissue called the linea alba. In most people, this gap is narrow. However, in diastasis recti, this gap widens, and the linea alba becomes thin and stretched. The result is a visible ridge or dome shape down the center of the abdomen when performing a crunch, where the core bulges outward from the belly button to the lower sternum, rather than pulling inward. While most associated with pregnancy due to the prolonged outward pressure of a growing uterus on the abdominal wall, it also occurs in men, particularly those who have spent years doing heavy loaded exercises with poor bracing technique or who carry significant abdominal weight. Individuals with diastasis recti often experience low back pain and pelvic floor dysfunction because the core can no longer stabilize the spine efficiently. Many mistakenly assume they simply have stubborn belly fat or weak abs and train harder, which in some cases can worsen the gap rather than close it. Specific corrective exercises exist for diastasis recti, and it's important to note that standard crunches and sit-ups are typically contraindicated. These subtle, often overlooked variations demonstrate just how unique and intricate the human body truly is, continually adapting in ways we rarely comprehend.